Thank you, Eli. Thank you all for coming tonight, and in particular, I want to thank all the ladies for staying in the room when the firemen were outside. It's really appreciative. I was worried that you're all going to leave on us. So oftentimes when I'm asked by my colleagues why I deal with pain, they ask me the question like this. They say, why would you want to deal with pain? Because we really don't like having to deal with it. And unfortunately, this is the case with a lot of different physicians and healthcare professionals. But I want to make it clear to you that there are healthcare professionals out there that want to help with pain. And sometimes it's a journey to find those. So when I have to answer that question, I explain, well, from a scientific point of view, it's really wide open. There's so much I can look at in terms of how pain is affecting us. And from a clinician point of view, I look at it and I say, well, it's kind of an all-encompassing condition. It affects us in so many ways. It affects, obviously, our pain levels, but our sleep, our mood, anxiety levels, our quality of life. And so I look at it as kind of a challenge. And I like to be able to think I'm trying to help my patients. So I guess that's my best answer to them. One of the things about pain is it's extremely complex. It's a very complex condition. There's many different conditions that cause pain. And for example, when I'm asked, what is chronic pain? Many people have the notion, well, it's something like breast cancer. Or it's something like multiple sclerosis. But then I have to try my best to explain it's actually a whole host of conditions ranging from arthritis to back pain to fibromyalgia to neuropathic diseases like diabetes and everything in between. And many times it's two conditions in the same patient. So the first thing that it's important to understand is when you go to see your doctor, pain is very complex. And doctors get about 1 hour of education during medical school on pain. Now, if you go to a vet college, 20% of your time is going to be about pain. So you have to keep that in mind when you're going to see your doctor, that the training wasn't always there. It's getting better now. It's getting better. We're doing a lot more teaching at the University of Calgary in the field of pain, but it's still not where it needs to be. But keep that in mind. And when you go in, think of yourself as a team member in terms of treating that pain along with your doctor. Many of you may have also heard the term, it's all in your head. Who's had that explained to them when they saw their doctor? It's kind of a well-meaning suggestion, but of course many of you probably didn't like that suggestion, right? It doesn't sound very good when somebody comes across saying it's all in your head. One of the things we've learned over the last 10 years is that comment is actually a little bit true. Because even if you have a pain, let's say only in one area of your arm, we know now that you actually develop a lot of changes in your brain. And so there are some elements of this that are in your head and actually in the brain. So it's very important to keep that in mind as well, and that adds to the complexity of pain. Finally, pain is extremely common. It affects 1/3 of the population in a lot of the studies that have been done recently. That's 1 in 3. Can anyone out there name another condition that's that common for a medical condition? Neither can I. This is an extremely common problem. So us as a group, patients working in terms of, with us, with healthcare professionals, need to bring this to the forefront and talk to government, talk to your MLA, talk to them about how the resources are not being there. Ask them why pain only gets 1/100th of the funding that cardiac diseases get. You know, they should be able to provide something about that. So, in terms of, let's talk about defining chronic pain next. So, pain that's been present for at least 3 months is usually the definition of chronic pain. So many of us bump our elbow and have pain for a few moments. Many of us will have had a sore knee or a sunburn that's lasted several days. These are all kind of acute pain. Chronic pain is that pain that's gone on for at least 3 months. Now, why we make that designation is usually when pain has been present for 3 months, it's often likely to continue, unfortunately. So usually at that point, it's become chronic and kind of part of us. So that's the reason why often we make that definition of 3 months. Many acute pains, on the other hand, resolve. And so many of them don't go into becoming chronic pain over time. So that's the notion of chronic pain itself and why we diagnose it that way. Now, the diagnosis of chronic pain is something that would take hours to go over, if not days. It depends on what kind of condition the patient has. So when a patient comes in to see your doctor, when you go in to see your doctor and you have, let's say, arthritis, the diagnosis that the doctor is going to go through, the process is going to be different than if you go in with low back pain, if you go in with shingles, if you go in with diabetes, they're all going to be very different. And when you go in, they're going to do crazy things to you. They're going to be checking your reflexes in an area that's not affected by pain. They're going to be pulling out little pins and touching your skin. This is with a purpose, okay? So when you go in, you should expect your doctor to analyze that area that you have pain over. They should be checking over that area, but they should be checking other aspects of your body as well. They should be able to delimit it. And the reason for that is they want to come to a good diagnosis. So I have another question for people in the room. How many people in here had their pain condition diagnosed at the first doctor visit they went to? 1, 2, 3. Okay, how many took 2? How many took 3? How many took 4 or more? You notice that's the majority, right? Now, why is that? So that goes along with a few things that you have to keep in mind. Pain is complex. Number 2, pain is not well taught in medical school, so doctors will vary in terms of their knowledge and comfort with it. And number 3, even though you'll go to 2 doctors with the same condition, sometimes they'll differ. You know, we're human. Sometimes we do make mistakes. Sometimes we have a different opinion than the other doctor. And we do not have one test to diagnose pain. It'd be nice if we had a blood test, right? If we had a blood test, you could say, aha, you have pain, it's this. But of course, this does not exist. Maybe one day, but not at the moment. And so instead, what it takes is a very good history, a doctor that spends time with you, talks about things, will go through and do the proper exam, and then perhaps do testing if needed. If you go to your doctor with fibromyalgia or shingles, you may not need any other tests. They may be able to make the diagnosis right there on the spot. However, if you have another condition, like maybe it's a disc herniation, maybe it's neuropathy, you will need other tests, so it depends. So again, everything is variable. Now, the time it takes to diagnose pain is also lengthy in many patients. So if you can see on this slide here, there are some patients, maybe up to 1/3, that will have less than 3 months to diagnose their pain, but the majority are going to take much longer. And look at that line for more than 2 years. That's 20% of patients. Now, as doctors, that's frustrating because a lot of us have a belief that when your chronic pain is there long enough, it becomes kind of instilled or part of you. And we'd like to be able to get on top of it as soon as possible. So part of this relates to getting better education to doctors, but also for patients. We want our patients to take a very active role and be very knowledgeable about their condition, their treatments, and know what they're doing and what they're coming into the doctor with when they go to see them. I'm going to address that with a tool you have in front of you in just a few slides. Now, many of you may have heard the term of a multidisciplinary approach, and this means that you've got actual multiple people from different healthcare backgrounds trying to help your problem. This may start with a nurse, it may also start with a physician, but it'll involve other team players. It may involve a physical therapist. A physical therapist is very good for teaching things like stretching exercises, knowing your limits with mobility, etc. It may involve an occupational therapist who's very good at knowing what kind of tools will help you. If you have sciatica, perhaps a cane will help with balance, etc. It will also involve a pharmacist who will know those medications better than any other team player. It may involve other people like a psychologist who you're going to hear from today with Dr. Tanzer, and a social worker. The team is very large. Now, the notion of this team is that they're all there to help the one patient, and they're going to work together. It's not going to be like you're going to see one doctor in one part of the city and then travel out to Airdrie to see another doctor there. They're all going to be localized within one center, and they'll have active communication ongoing about your problem. In Calgary, of course, that's the Chronic Pain Center that has the best kind of example for a multidisciplinary approach. Now, management of pain, again, is very complex. And this is difficult to say where this should start, but in my opinion, mostly this should start with self-management. And this begins with understanding and education. We've got a great internet out there, but it's full of good and bad information. But sometimes you can incorporate what you learn from that along with other health professionals and other patients. And with networks like this, perhaps other things like more association with the Canadian Pain Coalition, more support groups can develop, and you can have actually other peers that you can fall back on and ask questions of. There's other things you can do as self-management too, beyond understanding and education. One of the other things is often acceptance. There are many patients that will go from doctor to doctor attempting to come up with a diagnosis, and they'll have maybe a few different diagnoses, they've had several trials, but they're still struggling and they haven't come up to an acceptance of that condition. And when you don't have an acceptance, often you're not very accepting of the treatments or the diagnostic testing that's being provided to you. So at some point there has to be a time when you reach acceptance with that condition and your diagnosis. Discussion with family and friends is also critical. How many people in here talk about their pain with their family? How many people have never talked about it with their family? That's good. So it's only a scattered few. But it's very important because when you're at the dinner table, it's easy to have somebody down at the end of the table show off their cardiac scar, right? Oh, look at my cabbage. Or somebody say, oh, look at my knee replacement. How do you say, look at my fibromyalgia? How do you say, look at my diabetic neuropathy? You can't. They can't see it. If they can't see it, they often have a lack of acceptance about understanding it unless they actually talk about it with you. So it's very important that you talk with peers, family, friends, support. Support is very important. The other thing that's very important for chronic pain is exercise. As much as you can, it's very important to keep moving, keep doing things as much as you can. Work as much as you can also is very important. People that fall into a shell and avoid being out in society, do not go out and be active like they once were, often do worse when it comes to long-term prognosis. And so they have more difficulties over time with levels of pain, quality of life, etc. Now the next thing that comes up is when you go to your GP. So you're going to go to your GP, and unfortunately many GPs are strapped right now. We don't have enough of them. In Calgary, we're severely strapped for the numbers of GPs. So when you go in, you may only get a 5-minute assessment. And many of them will tell you that they can only see you about one condition. Unfortunately, this is because they've got so many other patients they have to get to. It's not always their fault. So please have some sympathy for that aspect of it, but also make sure that you get yourself well known. Now, how can you make the most of those 5 minutes? First thing is go in with a plan. So you want to make sure that you've got notes written down about your condition, how it's been affecting you, how long it's been there, what you've been doing to treat it. And then there's going to be a tool I'm going to show you that you can bring in with you as well. And if you explain that you've had doctors at conferences tell you this is the best way to do it, often those doctors you go to see will be more accepting of that. And they will be less likely to toss it aside. But try your best to make sure you're a team player and that you're going to spend those 5 minutes as best as you can. And hopefully those 5 minutes become 10, 15, 30 minutes on the subsequent visits. Initially, you may be placed on a medication. This medication is often considered like a trial, and it may be used for several weeks or a month or more. How many people would say that the first medication they ever tried was the most successful for them? 1 person, 2 people, 3 people. So obviously a very select few, right? That's a minority. Again, this is not unusual. There's often a fingerprint of a patient that matches up with the fingerprint of a medication, and sometimes it takes a bit of searching. If you go online and you look at drug studies that are done, and many of us have been involved in those studies, those are not the same patients as many of you in the room. They're different. Many times it takes 2, 3, or even 4 medications to get to that level. How many would you say that you've had one medication that was successful and you didn't need more than one? You didn't need 2 or more? So very few. How many would say they've needed 4 or more to help their pain on a regular basis? So again, that's probably a majority in the room, right? And so this is often the case, and it's because pain is very complex. There's so many different aspects of pain that you normally need different ways to attack it. So when I see patients in my office, I explain, well, if you had a baseball team, you probably wouldn't line it up with 9 shortstops, right? Who'd be pitching? Who'd be center fielding? You need to have different types of players for every kind of role, and likewise, we've got different medications that can help with different aspects of chronic pain. So it's not unusual for us to need to combine medications. Sometimes you actually need to stay healthy too. So when you develop chronic pain, there can be a notion that you don't want to move, you don't want to act, And then other conditions can develop, so things like high blood pressure, diabetes, cardiac disease. As much as you can, really try to keep those other conditions at bay and stay healthy. If those other conditions become a problem over the years to come, your pain is likely going to be worse as well. So getting involved is critical. You want to make sure you're explaining to family and friends, talking with your GP. Don't be embarrassed about this. You should not be embarrassed. You should be able to just go in and explain your symptoms right off the bat. Make sure that you've got a team around you, whether that team be your family and friends and your GP, or maybe it's a multidisciplinary clinic. It differs from person to person. Recognize your obstacles, and if there are too many obstacles in your day, look to see if you can avoid some of them, or at least make some of them lower. Set appropriate goals. This is all very important. A couple other things I just want to mention. It's very important that all of you try to read and understand your medications and your condition, because really you're using them for your own body, and if there are things that are going to be about those medications that aren't going to be good for you, it's your body. You should know about it better than your GP or any other doctor. You should know about it better than I. And so read about those medications and understand about what they could do, how they could affect you, and how they could work. Be part of a team, as I mentioned before, and consider all the medical professionals part of your team. That includes the pharmacist, psychologist, social worker, physical therapist, occupational therapist, doctor. All of them are acting as a team on your behalf. And be aware of expensive fixes. Many of you have heard of things where you can pay $1,500 to have this done and get this fixed. I have a patient of mine right now in Mexico that's getting air blown into his spinal cord. I have no idea why. It's costing him $1,500 a week, and he's been there 4 weeks already. And things like this that are not proven, if they were working, trust me, your doctors would be using them on a regular basis. Last thing I want to mention is you have something on your desks or your tables there that is called the Brief Pain Inventory. Sorry, I just have to grab that. This is a very quick 5-minute tool that you can take with you to your GP or whatever doctor you're seeing, and it explains a lot about your pain. So if you look through it, the first question, of course, is going to be yes, but this helps differentiate people in studies that have pain or no pain. And then there's a body diagram where you can draw in the areas of pain that you're most affected by. Yes, you may have had that shoulder bother you for a week, but geez, your lower back and your right leg have been bothering you for 2 years. You probably want your doctor to concentrate on your back and your legs. And then you can grade your levels of pain as worst, least, and average in the last 24 hours. And that's going to vary. I've had many patients that will come in and write 10, 10, and 10. And that can happen. You can have such severe levels of pain that it's always that way. But it's more important for your doctor if you find out, gee, the pain at night is really bothersome for me. That's when it's an 8 or a 9. During the early morning hours, it's only a 3 or a 4. Your doctor might say, maybe we need something that can help you more with your nighttime pain then. And then on the second page, a list of treatments that you're taking. And I would also encourage to list the treatments that you have taken in the past. Then your doctor doesn't have to waste time on that and talk about things you've already attempted. That's, again, going to save a lot of time and a lot of mistakes that could be made. And then lastly, talk about how much relief you've had. Again, if you've had 30 or 50% relief with your pain, that's pretty good. Giving another baseball analogy, if somebody gets 30% pain in my clinic, I consider that like a double. 50% pain is like a home run. 100% pain is pretty unheard of. That's like a grand slam, bottom of the ninth, 2 strikes. Okay? But you can help your doctor by telling them that. And then lastly, you can talk about how pain has affected your activity, mood, walking ability, your ability to work, relations, sleep, and enjoyment of life. And this is really critical, and this will summarize very quickly for your doctor what they need to know. So with that, I'm going to hand it back to Eli and Brian Abernathy, but I thank you for your attention.